Hi everyone. Um, can I confirm that you can see the slides?
Yes, sir.
We can see.
Yes.
You can see the slides? Okay, that's fine. So if the slides are not moving, then let me know, but hopefully it will be all right. Okay. So sorry for the delay. We were streaming the carbapenems and antibiogram, so analysis. So that's why it was a bit delayed. But in this one, I will try to give you an idea that how NHS works, how NHS microbiology works. So these are the topic that we will be discussing. So we will discuss about NHS, the corporate structure of NHS, how the microbiology department is, like the governance structure, the laboratory, what we do as a microbiologist, what time commitments do you have, what is the pay like, and what's the training structure. And then I will open it to all of you, and you can ask me questions if you have any. We wouldn't discuss any questions or the exam on this one because we had sessions already on that one, and those information are available on Moodle. So let's crack on. Right. So before 1948, NHS was established in 1948, and before 1948, the situation of England or UK was like lots of private practice that we are quite familiar with. I'm originally from India, so I know exactly what was the situation like in India and many other countries like us, that there was loads of private practice. There is some sort of government setup. There is lots of private hospitals. The situation in England or UK was like that. So loads of private practice. You might have heard of Harley Street. So there was loads of, how I can say, eminent physicians who used to be there. And also there used to be things like workhouse and other things. So if you had money, then you could have good practice. If you don't have money, then you cannot. Um, so Ramya, I can see that you are there. Did you find difficult to follow the link that I shared in Moodle, in WhatsApp group, or Rubina?
No, sir,
No,
I
Dr.
didn't have
Surya.
issues.
No.
Okay.
No,
Okay.
it's fine. No.
Okay. If one of you can just post a message on the Moodle Cloud WhatsApp group to say how you joined the link that you used to join, because I think few people are actually struggling to join. So after 1948.
Sir, we cannot hear you, sir. You're muted. You're muted, sir. You're muted.
Yeah, can you hear me now?
Yes.
Can you
Yes,
hear
we
me?
can hear you.
Yeah,
Yes.
yeah. So in 1948, all the organization was combined, and it was formed. The NHS was formed. There is still private practice, and there is still private practice in England and Scotland, in UK, but the number is very small. The small number of consultants do private practice, but most of us kind of dedicated to NHS, which is like a government setup, and we work there. So NHS is the predominant organization, healthcare provider in England, but there is still some private practice which exist, small numbers. So the NHS is funded by the taxpayers' money, and this fund not only fund the hospital, and everybody in UK actually get free service. So it doesn't matter whether you are coming from just a little bit of cut, or you are coming from for a prosthetic joint replacement or prosthetic joint surgery. Everything is free. So it says cradle to grave, everything is free. It might take time for you to get the joint replacement, but still you will get it free. But this taxpayer money doesn't come to NHS directly, and not only NHS. This taxpayer money also funds social care, also fund community health, and NHS. And there is an organization called Integrated Care Board who actually take the money from the government and decide that what kind of money hospital need and what kind of money health other community healthcare need, and distribute that. So if we want some money for our hospital, we have to go to ICB and tell them that this is what, in simple terms. There's a lot of complicated process involved. So secondary care, which involves the district general hospital and the tertiary hospitals, are called secondary care. And secondary care closely work with general practitioners. So general practitioners are also part of NHS, but they work in the community. So they are kind of, if you are in a setup where you find there is a private practice there, so they are like private practitioner, but they are employed by NHS. So they will, so say for example, in my community, there will be a GP. My area, there will be a GP who will be looking after all the patient in this area. So I can register to that GP, or if I want, I can register a GP somewhere else as well. But that person will be my first port of call. So if I get I'm not feeling well for a few days, I can go to hospital A&E, or I can book to the GP, and GP can look at me. So these are the primary care. And most of the time, the primary port of call is GP, where patient goes, and then GP is referred to the district general hospital or tertiary hospital. Patient come to district general hospital and they get seen, and then if they find that the patient district general hospital, the service is something that cannot be provided in district general hospital, then they will go to tertiary hospital. So for example, transplant will be done in tertiary hospital, or a major hematology oncology unit will be in tertiary hospital. So if you are in a microbiologist in tertiary hospital, then you will be looking all these things. If you are in a district general hospital, your remit will be slightly less than that. So you may not be looking at all sorts of transplant patient or complicated bad patient on a regular basis. So this is GP actually call you. So if you're a microbiologist in either setup, then GP might ask you for advice. So if they get a patient who has infection and they are not sure what to do, they will call you and ask for advice. Similarly, there are a lot of community services. For example, here, community services could be care homes, nursing homes, palliative care, respite care, community nursing, urgent care, rehab, multiple different type of community services. So these are the area which supports the patient as well. Now, I'm being from India, I know that the nursing home concept is slightly different. So that's why I think I should explain it a little bit. In many countries, nursing home means that it's a type of hospital that you just go there. It's a small hospital. But here, say a old patient come to hospital and they get treated for their whatever problem they came with, and they are ready to go home, then the social worker will assess the patient. And if they find that the patient can manage in their home fine, they will send the patient home. We'll send the patient home. But if we find that the no patient cannot manage at home, then it will be too risky. Like if they try to make a coffee, they might burn them, or there might be dementia patient, cannot look after them well, then we'll send them to care home, where there will be some carers who are not nurses or doctors, but they're just carers. They will be looking after this patient. But if that patient needs some nursing need, some medical need, like this patient need a regular medication or not well, need to be seen by somebody who is a healthcare worker, they will go to nursing home. So nursing home will have all these patients, and there will be nurses, community nurses, who will be looking after them. And there might be a GP who they might contact if they find there is some medical need. So somebody like in a nursing home, the nurses think that this patient is having an UTI. So they will contact the GP and ask for advice. Palliative care is something where the patient go when they are dying. Respite care, these are typical, but I think not that relevant to us, so I'll skip that for the time being. So all this another group of organization which we work closely with, that is called UKHSA. So you already heard of UKHSA and what they do. This is a huge organization, UKHSA. This is called public health. So this is public health is an executive body under Department of Health and Social Care. So they not only look after the infection side, they also look after things like chemical hazard, bioterrorism, biological hazard, radiological hazard, and they try to protect people from all these type of hazards. So infection is only part of that, but they are heavily involved in it. And they work quite closely with secondary care and GPs to deliver that service. So what they have done is they have divided it. So there is some central laboratory, like our main central laboratory are in London or like some are in Edinburgh. So that's where we get our specialized test. For example, if you want test for viral hemorrhagic fever, then viral hemorrhagic fever is a category 4 organism. So if there is a suspicion of viral hemorrhagic fever, a patient presented to a district general hospital with viral hemorrhagic fever, then we will not process the specimen. And what we'll do is that we will call the public health laboratory services in Colindale or Porton Down, and we'll tell them that we are suspecting viral hemorrhagic fever, and we'll send the sample to them. Similarly, there are experts there who deal with this kind of specialist problems. So say if tomorrow I suddenly get a suspect there is an avian influenza outbreak there in Northeast where I practice, what I will do is that if I get a specimen, I'll speak to probably the local virologist who will be like tertiary care virologist, and then I will speak to the specialist in Porton Down or Colindale and inform them and ask their advice. Similarly, if I suspect a bioterrorism, straight away I'll pick up the phone and inform public health, regional public health, and they will initiate a cascade of reaction and they will tell central public health, and then all the bodies will be alerted of a bioterrorism event. So it's like a quite coordinated work that they do. So anything related to, if you think of anything related to community, that is looked after by public health. So to give you another example, say I have a patient who is, I have a couple of patients with same salmonella infection. Now, if I suspect that there is an outbreak going on of salmonella, then I will contact public health saying that, see, I think there is an outbreak going on. And what they will do is they will get in touch with so public health consultant will get in touch with the environmental health officer, and they will, if it's like a food related infection from a shop or something, they will send the environmental health officer to the that shop to see that what their hygiene is like. So it's and they will find out if anybody who has eaten any food from there and admitted to another hospital, because I wouldn't know if another patient has been admitted to another hospital in the region or somewhere. Public health has that means to go and coordinate that and find out what's the extent of the outbreak. So anything related to community, we have to tell them. They help us to manage that. Our remit is within hospital, but their remit is too much. So if I get a pertussis patient in our hospital, then I will manage it. I will arrange for the prophylaxis for the staff member. I will arrange for the prophylaxis for maybe the mom, but anybody else in the community, that will be public health UKHSA role. So I will inform UKHSA that there is a pertussis case in our hospital, and they will chase it from there. They will go and contact the patient. They will contact the patient's family, who might have been the contact of this primary patient, whether they need prophylaxis or not. It's all their role. They also do surveillance. So when you get a E. coli bacteremia, when you get an MRSA, when you get an MRSA bacteremia, C. diff, all goes to public health, and they keep a record and they make strategy based on that information, how the public health action or how the hospital action would be maintained. So any kind of alert organism, you will find that there are certain things which say we need to notify public health, like E. coli bacteremia, Pseudomonas bacteremia, or MRSA, MSSA bacteremia, C. diff, carbapenemus producing organism, VRE. These are the things we need to inform as well. Same way, we need to inform them about any meningococcal disease, any pneumococcal disease. So whenever we get a meningococcal disease, we need to inform them, and we need to send the specimen, send the organism to public health laboratory so that they can type it. So they will type it and they will find out, is that type of meningococcus or pneumococcus in the vaccine group? So if it's not, then they will provide a strategy to the government that, oh, your vaccine group need to be expanded because we are seeing a lot of these serotypes in infections we have seen in last few years. So they have a really huge role there. So that's the Public Health England is involved with us. Then there are also other organizations which are involved, like GMC will provide registration for any doctors. So if you want to work as a doctor in the UK, Royal College exam is not sufficient. You need GMC registration. Without GMC registration, you are not allowed to work as a doctor. So you need GMC registration. They're the regulators. Then Royal College obviously will get the standard. They will train the doctors and they will ensure that the training part is okay. And there are organizations like NICE, BIA, BSAC, HIS, BASH, Viva. So they produce different type of guidelines. So these organizations have members from us. So for example, in microbiology body in HIS or BASH, one of consultant like me might be representing them. And we might form a committee and we'll produce guideline. So if there is like any SMI or anything going out, then they will ask these bodies to comment on that. So those comment into taken into consideration. So these are bodies formed by important people or medical people, non-medical people, important people, and who provide guidance or advices to government and other organizations to what to do. It's like an Israel network of information providers. Secondary care, that is now come to hospital. So secondary care is follow a corporate structure. So each hospital will have a board. So each trust will have a board. So trust concept is slightly difficult to understand maybe if you're not working in the UK. So you can think that, say, you sometimes have a group of hospital in your country who are under the same management. So that is a trust. So a trust might have 6 hospitals under them, or 4 hospitals under them, or 1 hospital under them. So that is the corporate body. And that each trust will have a board, a chief executive officer, chief operating officer, chief financial officer, and medical and nursing directors in their board. And there will be some public representation as well. It's just like a governance structure of a company, like board structure of a company. Then after those, under those will be different business unit. So surgical business unit, medical business unit, pediatrics, clinical support business unit, like etc. Now microbiology or pathology sits usually clinical support, but they can sit in depending upon which trust you are working. They might be inside the medical business unit or surgical business unit or clinical support. It depends upon the trust how they want to set it, but essentially they will be in a business unit. In our hospital, it's in clinical support business unit. And clinical support business unit has different specialties, which are like histopathology, microbiology, biochemistry, hematology, transfusion, radiology, oncology, and pharmacology. So all these specialties form this business unit. So there is a business unit director who is usually a medical person who look after the whole business unit, and he is supported by a business unit manager. And then there is an operational service manager. So if you have seen my outbreak modules on Moodle, then I have said that many outbreaks you have to ask the OSM to come. So OSMs are like mid-level managers who look after the everyday working of the hospital. So in outbreaks, often they join to make sure that the outbreak is managed effectively. So these are the operational service manager. That's where they sit in a business unit. And then there will be clinical lead. So I am the clinical lead for our department. So I will be sitting here. And I will be kind of supported by quality lead, finance lead, and HR for the business unit. And there will be operational service manager. So effectively, I report to, so my boss is business unit director, and business unit boss is medical director. But the operational service manager will be the boss of laboratory seniors. So these are like, when you say that laboratory technician, the term you use, that those are here called biomedical scientists. So biomedical scientists come from like a science background, and they are trained in the laboratory, and they become biomedical scientists. So the biomedical scientists, when they become senior, they take managerial role and they become laboratory seniors or operational managers. They report to operational service manager. There are some supporting staff in the laboratory who are not as efficient or as trained as biomedical scientists. They are called APs or MLS, medical laboratory assistant. Then obviously under me will be microbiologists and microbiology trainees. They will be reporting to me. So we kind of work together to form this group. So this is how we report to each other. So BMS and APs and MLA work in the lab. They report to laboratory seniors, and then they report to laboratory lead, and microbiologists report to me, like clinical lead or head of the department, and I report up there. Now, some of the biomedical scientists are actually being trained now in managing microbiology. They are called HSST training. So when you go to Royal College examination, FRC path, you might see that there are defined categories. So medical scientist route, this is the medical scientist route. So these people who are medical scientists are not MBBS. They are not coming from the medical route, but they are from a science route, and they often might have PhD, those sort of thing, and they will be training 5 years to help you in microbiology management. So they will be doing, if they haven't got a PhD already, they will be doing PhD. They will be doing Royal College examination. In that 5 years, they will be doing a leadership course, and then they will become a HSST. Incredibly difficult course, and these people who manage this are just terrific people, but very difficult to do these things. But they will be kind of, you might find when you are working in UK, you might find that the medical scientists route, these are the HSST. So they are very intelligent people. But problem is that they are not trained in medical, so they have to work extra miles to reach there. So how the laboratory work? So laboratory, we divide the laboratory into different benches, which might be common in most of the laboratories. So we have blood culture bench, wound bench, fluid bench, urine bench, genital sample bench, transplant bench if you are working in a tertiary hospital, serology, molecular mycology, and so on. So it's just sample get distributed into different benches depending what type of sample, and they process it there and send it through, which I expect common in most microbiology laboratory. We follow this standard. Most of the UK microbiology laboratories follow UKSA standard, and that's where you will be tested on in the exam. Some of the laboratory follow CLSI standard like us, but we are moving to UKSA standard. CLSI standard is not that common in UK. So UKSA is the main standard. UKSMI, all our SOPs are based on UKSMI. Very important, very, very important for the exam. And then the laws, recently in the exam, they are asking about laws. So you need to know about the law which underpin the whole health system, which is the Health and Social Care Act and Health and Safety Act, and then also COSH. So these are the laboratory acts which will be underpinning us, how we do things safely and effectively. Then we get scrutinized by UKAS, and you all know that there is an ISO standard for that. So UKAS come and tell us that whether we are doing things right. Now, one thing to remember that the recent UKAS, recent ISO guideline which came out is quite heavy on competency. So I do not know how that will play out in the exam, but in part 2, you just need to know that there's quite a lot of competency issues there in the ISO. They will be judging everybody on their competency. But these are the standard that we have to follow. There is another standard that hospital has to follow called CQC. So CQC are regulators. So they come to hospital and make sure that the services are running right. But CQC do not come to laboratory because they have a memorandum of understanding with UKAS that because UKAS is assessing our CQC do not come to the laboratory. Then there are quality and safety is quite heavy, quite heavy on NHS laboratory, and we have a quality lead who look after all the validation, verification, and all this UKAS stuff, and make sure that we are following all the structure appropriately. So there is a clear governance structure and a specialty board. So specialty board is somewhere we discuss all the problems of microbiology, and usually the clinical lead chair the specialty board. In all UK laboratory, we have an electronic LIMS system, electronic laboratory information management system. So handwritten system is not there anymore, all electronic. So all the result will be put into electronic system, and then it will come to us for authorization. We'll release it, and it will go to the users in electronic system as well. So this is usually ICE or those sort of system where they can see the result. So everything is electronic, and more laboratory moving to paperless system. Like most of the thing will be done electronically. There is a surveillance system. So any result that we produce, we report it via a surveillance system to UKSA called SGSS, second generation surveillance system. This has been asked in the exam, so you better know that. So this is reported. So all the results get reported by SGSS system. This is separate from what you need to inform public health based on a important infection. So although the pertussis result will be notified via SGSS, you still need to inform UKHSA about it. Okay, bench round. So we do bench round. Bench round means that every morning we tend to go to blood culture bench and fluid bench, and some hospital go to more benches like transplant bench or other benches, and go through all the results to see that if there is anything important, and we take down the result, and then we move and go to the ward to tell the result. So bench round is kind of an interaction between the biomedical scientist and us about the specimen. So it is an important area because we can tell them that do the additional antibiotic, or if they have made any mistake, then we can tell them no, this is not right. I think you need to go back and look at that culture plate. And are you sure it is an MRSA? So have you done a MEK test, or these things you need to send to reference laboratory? So this kind of interaction happens in the bench round. So that's why you get a lot of questions about intrinsic resistance or how to advise the biomedical scientist about it. So these are the things that will be kind of part of our daily working, and that's why you will get questions on what I can say, biomedical scientist questions. So 24/7 lab. Many of the labs are 24/7. That means they work round the clock every day. But some of the laboratory are still not 24/7, so they closes at night. Especially in low volume areas, like if you're working in a remote DGH, then you might find that they do not work. But the trend is that more laboratories are going 24/7. Now, reliance on automation. We have loads of automation in most of the laboratory. Although we still do identification, like put it on culture plate and do some bedside tests, like tabletop tests like oxidase, catalase, but all those other tests that we used to do in old days, like putting in a test tube, those are going. So most of the laboratory, what they do is see the culture plate, do an oxidase test, catalase test, and then put it on MALDI, and put it on some automated sensitivity. Some hand sensitivity done, but automated sensitivity is quite common. Multiplex PCR is quite common. So CSFs go into things like BioFire, or which kind of give you an answer within an hour. So, but automation is also expensive. So we have to balance the the expense with the benefit, that what is better. But there's a lot of automation. So things like Kistra, which can actually process a specimen from the beginning to the end, those kind of systems are also being used. So quite automation heavy in the laboratory. When I was training like 10 years back, at that time we used to still do API. We didn't do, as a microbiologist, we never do API or process things in the laboratory. It's all done by the BMS and AP. We heard, as a consultant, I haven't processed any specimen in last 10 years. I haven't done anything in the laboratory. My job is very clinical. So everything is done by the BMSs, including API, MOLDI, everything. Category 3 processing, everything is done by the BMSs. They release the result. We give them advice on what to do based on our clinical knowledge. But if you have a concept that as a microbiologist, it will be very practical in the laboratory, that's not the case in UK. We are very clinical, very clinical. Yes, there is a lot of in-house serology as well. And if we cannot do those in-house serology or PCRs in the hospital, then we send it to the reference laboratory where they get done. We closely work with local reference laboratory. We have local public health laboratory and various other reference lab. So all like things like typing is done in reference laboratory when we have an outbreak. So it will be important if you're going for part 2 exam, especially even part 1, that you read the reference laboratory manuals and see what tests they do and what kind of typing they use. You will find that manuals in microregister.com. In the preparation section. I have put all the links to the manuals for the reference laboratory. Right, so what microbiologists do in the UK. So our job is 9 to 5 job, very good job actually. We do not do nights. So I go at 9 o'clock, sometimes go at earlier than that, but usually I go at 9 o'clock and I finish at 5 o'clock. And then when we are on call, usually weekdays on calls are from home. So I come back home and I might get called by doctors who need advice on managing a patient, like changing antibiotics, or patient is not responding, what they will be doing. A critical patient being admitted from somewhere outside, they do not know what to do. They will be calling me for antibiotic advice. Or there is an outbreak in the hospital, they will be calling me for advice, but all from home. Rarely I have to go to hospital to manage it. And in my 10 years as consultant, I had to go only once because there was a huge rain and rain was coming through the windows. So they wanted me to find out which room can be used by the patient and which room is not safe. So I had to go to each room and tell them this is safe, this is not safe. But this doesn't happen. If we get an Ebola case from in hospital, or like a viral hemorrhagic fever, which we rarely see, if you are from a country where Ebola is common, you might find what big deal, but it is unknown because we do not have those kind of infection in UK. We get scared. So if an Ebola case comes to A&E, I might have to go, but most of the time my job is from home. I might get called at night, but it's rare. And if you are in a teaching hospital, then you usually get a registrar, a junior doctor who will be taking the calls, and that registrar will be calling you if they cannot answer the problem. So that's on call. Weekend on call, sometimes we have to go to hospital, like in the morning maybe, and then come back and work from home. Some hospital allow working from home all the time. And as the number of microbiology consultants is quite limited in UK now, we are in high demand. Many of the hospitals actually saying that, yeah, you can just come 3 days and work 2 days from home. So it's like that. So it's negotiable. When you become microbiology, depending on demand and supply, you can negotiate your job. Okay, usually our job is 10 PA. That means you are working 5 days a week and getting paid by that. Standard salary, so our salary is similar to any other doctor salary. Because we are microbiologists, we do not get pay less than a surgeon. So we get same pay as a surgeon or a cardiologist. And on call, if you do on call, most of the time is mandatory. It attracts additional payment. So typically like 8%, 5%, 8% on top of your basic salary. So a new consultant start around 94,000 pre-tax. And it's usually like less than 5,000 take home. But as you become senior, you tend to get more. As a junior doctor, you will be getting less than that. Usually very junior doctor just starting, they start from something like 35,000 per year. And then mid-range doctor around 52,000, 56,000 per year. And then when you become like specialist doctor, that is something that in the kind of like a consultant almost, but not consultant, it's like 92,000 around that. So what we do, we authorize the result. And if you get something important result like a blood culture positive, or if you get a CSF positive, then we go to the ward, talk to the doctors, give them advice, ask them, do you have any other uh, any other problem that you want to ask us? So we give them the advice. Sometimes we go to yeah, that's it. And then we also go to critical care ward round. So intensive care, we go every day and discuss the patient with them and then give them advice. They are very receptive of our advice, so we work very closely and we are really appreciated there that our advice is really appreciated. So the doctors here listen to microbiology. That's the most important thing. It's not like other country. If you tell something, that will be taken very seriously. We some other hospital go to other ward rounds as well. Like you might do a surgical ward round, you might do a medical ward round, gynae ward round. You can do consultation. So we get phoned about difficult patients. So doctors do not managing thinking about like penicillin allergy. They do not know which antibiotic to give, so they will call you. Or they have a patient who is not responding to say piptazocin. What antibiotic to give, they will call you. Sometimes we restrict antibiotics. So for example, in our hospital, ciprofloxacin is a restricted antibiotic because of C. diff risk. So if they have to give ciprofloxacin to any patient, they have to take our permission. So they will call you. We attend various MDTs. So it might be like an infection MDT, it might be endocarditis MDT, it might be diabetic foot infection MDT, prosthetic joint MDT, where you will be giving advice, you will be giving your opinion, and again, it will be taken very seriously. Lab troubleshooting, lab will be coming back with you with various questions. Like questions would be that this test for reference tests. So some tests that you do not do in the laboratory, you have to send it to another laboratory. But you may not need to send all the samples because there might be test requested by some clinician which is silly. You know that, like say infective mononucleosis, and the clinician is asking for EBV PCR. I would say no, it's not needed. Just do the serology. So that kind of troubleshooting. And then they might ask you about things like a plate is not available, what to do, or a disc is not available, or they might ask you, do you need additional sensitivity? They might say that we have isolated a pure growth of E. coli from a leg wound. Do you want the sensitivity? So you need to say, it doesn't look like the patient is immunosuppressed, most likely contaminant, you don't need to do anything. But or if it's a pure growth, you might decide to do sensitivities. It's up to you based on what you find from the clinical information. So you need to review the validation and verification data from the lab, mainly from the clinical perspective, not the technical perspective. That will be taken care of by the BMS and the quality lead. But if there is a problem, like there is a gray zone which is causing problem, you might need to say from the clinical perspective, do you think it's important? If you think it's important, then you have to come up with a plan. So you might say that, okay, there is a gray zone result and we are not sure about. So if any result come into gray zone, like an indeterminate, then we need to send it to the reference laboratory. So you give a backup plan based on your clinical. If you think it's not going to affect patient clinically, you say, no, fine, it's no clinical implication, so we'll just release it as an indeterminate. And maybe put a comment saying that if you are worried about this patient or this result, please discuss with microbiology or send a repeat sample. So you have to give that information to the lab based on your clinical knowledge. You will be involved in education. You will be supporting lab with UKSA accreditation. You will be representing lab in the various meetings like outbreak meeting or managerial meetings, various management meetings. You will be representing the lab as a microbiologist, and you will be reviewing the SOPs as well. So lab will make the SOP, but they will send you for final approval. You will support the infection control team heavily. They rely heavily on us to provide the clinical, provide the medical background and advise them. You will attend or chair ventilation group, water safety group, decontamination group. You will be supporting antibiotic stewardship. So usually a microbiologist chair the antibiotic stewardship group. So all these things are important, and that's why you get questions in the exam. You will be making antibiotic policy. So all the antibiotic policy are done by the microbiologists in the UK. So you will be involved in that. You will be making infection control policy. So you'll be giving input to the infection control nurses. You will support occupational health with their vaccine queries, their needle stick injury queries, things like that. And also you will be working together, working with public health and community. So for example, district nurses might call you about some complicated infection, complicated foot infection, and ask for advice. This is the training structure. So UK graduate, when they finish their medical school, they go into a foundation doctor, which is like used to be internship in many other countries. So they do foundation doctor for 2 years, and during that time they finish their MRCP, more or less. And then they infection, if they're coming to infection, they go to combined infection training, which is ID micro. And during that time, they usually finish part 1 FRC path. If they're ID trainees, that's all. They actually do not do part 1 FRC path anymore. They do CIC, and then that's it. They wouldn't do part 2. So infectious disease, pure infectious disease consultants do not have part 2. They only do CIC, and then they go out, do their CCT after their training. Microbiology trainees, on the other hand, will do part 1, and then they move to higher specialty training. So this one will be ID micro, this one will be microbiology. And then they will be doing part 2 FRC path there. Once the training is finished, they will get a certificate called completion of training, which is CCT certificate. And then they become consultant. So this doesn't mean having 2 exams doesn't mean that you become a consultant directly. You have to finish your training effectively, and your training body has to be satisfied that you are appropriately trained. So exam doesn't mean, it's like in MD, you do a exit exam and then you finish your MD. It's not like that. So training is important. Exam is a part of it. So when you come as an overseas graduate, you can join any part of the program, but you have to show the efficiency. So if you are joining a foundation doctor, in that case, you need to show that your qualification is similar to UK medical graduate. You have to undergo an interview and then join foundation training. If you are joining here, then you have to show that you have MRCP and you have competency of a foundation trainee doctor like in the UK, and then you can join here. Quite difficult, very difficult. And you have to, if you are going to consultant, then you have to show that you have competency of these doctors to join as a consultant. So you need to show that whichever level you are joining, you have to have the similar competency of the previous grade of doctors. And on top of that, you must have a GMC registration. So having the exam only will not get you a job. You need to have a GMC registration, and depending on where we are, you can get in. Now, to have a GMC registration, you need to have a PLAB, an English language test, or a full FRC path, or other qualifying examination like USMLE, Canadian exam, those sort of things, or sponsorship. So how to get sponsorship? I asked Royal College. They asked me that if anyone asks, direct it to them, direct them to them, Royal College. So if you want to find about sponsorship, speak to Royal College. And then by this route, you can get a GMC registration, and then you can think about entering the UK system. Now, this is showing that whether you can get into a training program. In my mind, getting into a training program as a non-UK graduate is very difficult. So there is an alternate route, which is this. So once you get the GMC registration, you can get into a trust doctor, or a specialty doctor, or a specialist doctor. So each level has their requirements. So trust doctor is essentially if you have a GMC registration, and if I'm employing a trust doctor, if I find that you have GMC registration or eligible for a GMC registration and you have an MD microbiology, if there is no other better candidate, I'll be happy to take you. Now, specialty doctors is usually similar, but part 1 examination considered desirable. So some hospital consider it desirable, some hospital consider it mandatory. So it very much depend upon the hospital who is employing. So usually you can get into a specialty doctor as well, but remember you need the GMC registration as well. So you can get specialty doctor. Now from this route, and specialist doctor is, so this one started like 35,000 payment. This is like 52,000 payment. This is like 80, 90,000 payment. And this one, you need much more competent. Usually you need part 2, but some hospital may employ you. Um, uh, some hospital may give you even with part 1 if they feel that you are competent enough. It's all demand and supply. If there is supply is low, then people actually happy to negotiate. So usually need part 2 and good experience, good amount of experience. Sorry about that. So good amount of experience, but then you can get into a specialist doctor post. Now, after specialist doctor, if you want to become a consultant, like same to me, like a consultant or say, like a doctor who has gone through that, then you have to make a portfolio like thing where you show all the competencies that is necessary, and then you send it, and this you get this certificate, CESR. That CESR certificate, once you have done that, you will be equivalent to CCT and you can become a consultant. If you find this too much, then you can get your FRC path exam and then you can apply for a locum consultant post. But this is based on demand, because if the demand is high, then people will employ you as a locum consultant and you can work as a consultant. You will get a reasonably good amount pay, consultant pay. Like that, but it will depend upon demand. So if somebody find a candidate who is more suitable than you, they might say that, okay, we are employing somebody else. But that is another route, that you do a first path and you become a locum consultant. Hope that explained that how the training works here and how you can get into the system. Right. So I will stop there. If you have any question, raise your hand, and based on the numbers, I will ask you. Right. Renu? Oh.
Yeah, good evening, doctor. Thank you so much first. You can hear me?
Yeah, I can.
Yeah, doctor, I have a few questions. What about the age? So, like my age is 52 now, say another 2 years. So if around 55 years of age, what are the prospects of getting a job there?
Age is not a matter.
Age is not a
Age doesn't matter really that much in UK. I mean, in the law, like nobody, if you're a good doctor and if you're like so proficient enough, then age should not matter. And how I can say, I for example, I mean I know 52 is, but I did 10 years of microbiology, 10 years of medicine, critical care, surgery, and lot of elderly care, stroke medicine, and then came to microbiology. So you can imagine that I didn't come to microbiology at a very young age. So it doesn't matter really. If you can go through the system efficiently, then I don't think the age will be a factor.
And for the part 2, is it really required to go in very depth, like pathogenesis? Some part of the microbiology is more like a theory. I hope you're getting it, and some is more practical based. So is it really, while we are studying, because is it really to go into the depths into the theory part, or we should just have an idea about it for part 2?
You have to go really in depth. Yeah, sorry, Vinita is gone. You have to really go in depth, but you are right. I mean, when I suggest that you read for the exam, you read it as in a practical way. So like you are managing a patient.
Yeah, correct.
Yeah, so just reading and sitting and reading the theory will not help you. So you need to think about, you need to think like you are managing a patient. So when you are, what kind of clinical presentation a patient with listeria may have, and then what investigation would you do, what what result can come out, and how are you going to interpret the result, how are you going to pass that result to the clinicians, what treatment are you going to give, and what the complication of the treatment, what would you do if you fail the treatment. So it will be very practical way. So you should not just sit down and read the manual. That will not help you pass. So you need to read it with practical.
And like how we had an MD exam in India, how different is part 2 compared to the MD exam of India?
I haven't taken MD exam. I came to UK after MBBS, so I wouldn't know how the MD. But part 2 exam is very problem based.
We have clinical attachments also we can get after.
You can get clinical attachment. Clinical attachment you need to find out yourself and find out an NHS trust hospital who is happy to give you clinical attachment. Because the problem is that if you go, then that is a load on the consultant body. As you say, UK is already struggling with number of microbiologists. So if they have to supervise someone, they find it difficult, and that's why getting clinical attachment is becoming more and more difficult. I started as a clinical attachment in UK back in 2005, but the situation has changed a lot. And also clinical attachment is unpaid job. So you have to survive in UK on your savings.
Correct.
And then do the clinical attachment if you find one.
Okay, and as per your presentation, we have understood for if we have done MD microbiology, we have to give FRC part 1, part 2, and then we get the GMC registration, and then we have to apply for the under training like CCT like that.
No, if you FRC path exam, MD microbiology will just tell me that you are qualified as a microbiologist and you will be eligible for FRC path examination.
Yeah.
And then you can give FRC path part 1, part 2, and then if you do the CESR portfolio, and then you can become a consultant. Just being an MD microbiologist will get you a very junior microbiologist job with a very low pay, but you won't progress much by just doing MD. So,
but then how to get the GMC registration? We have to give PLAB mandatory, or there is any other way without giving PLAB?
This PLAB, English language exam, or full FRC path, or USMLE, or sponsorship.
Okay, so another the second route is if we don't want to give PLAB, we go for FRC path, part 1
you have
and
to
part
finish completely. Yeah, full FRC path, not part 1, part 1, part 2 both.
Part 1, part 2, then GMC registration, and then we can apply for local consultant.
Not consultant. You can apply for locum. Yeah, you can apply for locum consultant. Yes. Yeah.
And along with the CSR.
Well, CSR is a portfolio that you have to make, and then you have to pass to GMC, I think, with the help of RCPath, and then they, if they approve, then you get to become a consultant.
Yeah. And doctor, this Moodle is sorry, a very basic question. Is it paid or unpaid? The Moodle you were talking initially.
So Moodle is paid. So I am still building it. It is not any company. It is just me building it. So after my full-time work, so it takes a lot of time to build it, and that's why it's taking like more than a year for me. So that's I mean, and Moodle itself is a paid platform. So if people register, then I have to pay Moodle for that. So while building it, that's why I don't encourage people to register, because if like number of people registers goes up, then I have to pay more. But that if anybody is very interested on what material now there, then they can fill it, they can join. But that £20 fee is there so that I can actually cover the Moodle cost. But once it is finished, most likely it will be higher than that. But I haven't thought about it yet. How much I'm going to charge is not. I'll think about it later once finished.
Future, when can we expect it? Any?
Very good question. I am hoping I think I would need few more months to kind of make the virology section more strong and just finish a few bits, make some more questions. Like I'm hoping to put like 300 MCQs and kind of at least 100 part 2 questions. So I think we'll need few more months.
And for the sponsorship, we have to go to NHS. You will not talk about it anymore.
Sponsorship is I cannot do anything about sponsorship. You need to go to RCPath to ask about it.
Right. Thank you, doctor. Thank you so much.
Okay, Tausif.
Hello, sir. Am I audible?
Yeah, I can hear you.
Yes, sir. So thank you for the class, sir. It has really helped us understand a lot of things. And I actually have a query regarding the combined infection training certificate course, sir. I had come across among the various specialities in FRC PAT, and I had come across this certificate in diploma section citing a CICE course. And hello.
I haven't heard of any CICE course, to be honest.
I'm sorry, sir. I'll check it up again.
CICE is an exam. CICE is an exam which is taken by the Royal for the people who are in the UK training program. So previously it used to be taken by the people who are doing combined infection training, whether they are in ID consultant, ID micro, or microbiology, they all used to take CICE. But recently in the last exam, they have changed it, and looks like that CICE is only taken by people who are doing infectious disease on its own, or something else on its own. So if you are a microbiologist and you want to take part 2 exam, then you should not go for CICE.
Okay, sir. So basically, it has no role except if you are willing to go into ID course.
If you want to go, if you want to become an ID consultant, then it might have a role, but I really cannot help you with that, because I do not know how junior doctors can join.
I got it, sir. I got it. Since the date of the exam of both of them, and even like it has microbiology aspect as well, I wanted to know what is it, and will it be helpful for a medical microbiologist?
Sorry, I didn't get your question. Say it again.
Will it be? It wouldn't be helpful for a medical microbiologist, right, sir? That is what I wanted to know.
It won't help you as a medical microbiologist, because if you take CICE exam, you cannot take part 2. That's what the Royal College is saying.
Okay, sir. Okay, sir.
And if you want to be a microbiologist, you want to take part 2.
Sir. Okay, sir. Thank you, sir. That was my doubt.
Okay. Anusha?
Hello. Hi, Dr. Surya. At the onset, really, I want to thank you for your lucid presentation. I loved every aspect of what you're doing. Of course, the Moodle is out of the world, but even the presentations and the time you're spending with all of this is very commendable.
Thank you.
I just wanted to know, what is the role of a microbiologist administratively in the UK? Because here essentially we end up doing everything like you're aware of, but essentially I want to know, like, how is it in the UK?
So if you become clinical lead, then it becomes really difficult. So I have become clinical lead last November, and I'm not liking it, to be honest.
Okay.
So you need to answer a lot of emails. Look after the kind of you need to solve all the problems of your colleagues, like their leave application you need to approve, their study leave you need to approve, and then you need to kind of join various meetings, so management meetings, and you need to give feedback about the lab, and you need to feedback their things to other meetings. So it's kind of doing loads of meetings, and then you need to as a clinical lead, you will be responsible for the laboratory, like all the SOPs, and it's responsibility of you. So you need to go through all the SOPs, and you need to make sure you kind of approve them. So it is not management of clinical things. It's a lot of like paperwork, emails, meetings, those sort of things. Not good. Not good. Don't want to do that.
Okay, thank you. Much. Thank
you. Aya?
Hello, Doctor. First, thank you for this informative session. I have benefited a lot from it. I just have a question to make sure that I have understood it right. If I am an overseas graduate and I pass through the FRC PAS exam, then I can work in UK after GMC registration, but just as a junior microbiologist who is low paid. Is it right?
So if you done even without FRC path, you can become this doctor.
Trust doctor.
Yeah. So that is like that is like a very junior doctor. So how I can say your role will be something like an intern or SHO. Okay. And then once you have done your FRC path part 1, you will be probably going to this doctor. So which you can consider as a registrar.
Okay.
So
but after part 2.
After part 2, and if you have enough competency and you have enough experience, like I think there is certain years of experience.
In UK, You mean experience inside the UK? It should be an experience inside UK, not outside it.
No. It can be experience elsewhere as well. So so if you've been like a, say, I don't remember exactly how many years, but like 6 or 10 years, something like that. If you have that kind of experience and part 2, and if the hospital is happy with then you can become specialist doctor. So specialist doctor is something like, you can think of RMO. So they are like not the consultant, but they are like RMO. So they do like consultant jobs, but they do more clinical. So good thing is that they won't have that many administrative responsibility. They'll be doing mostly the clinical work. So you can become there, and your salary would be almost similar to a first-year consultant.
Okay, but to be a consultant, I should finish a training within the Royal College, yeah, to get the CCT certificate.
If CCT is only available if you got into UK training program. If you are coming through this route, CCT is not available. Equivalent is CESR.
Okay, I got it now. Okay, thank you very much. Thank you, sir.
Okay, right. Gulshin?
Hello. Firstly, I want to thank about this conference. We need support, really need. And I'm a bit confused about the exam of MRCP. I am a medical doctor and a medical microbiologist, and I am experienced in this specialty for 8 years. And I want to be a medical microbiologist in UK, and I have applied the FRC Part 1 for the spring exam. But I'm confused about if I need to enter MRCP first.
That's a very good question. So this CESR, so if you want to practice in microbiology, as I said, that you need GMC registration.
Yes.
And then you need to apply for a microbiology trust doctor or specialty doctor job and go through interview, shortlisting and interview. So this one doesn't really need FRC path for you to get in. It needs GMC registration and hospital to be happy that you are microbiologist. For example, when I was trying to get somebody for a trust doctor, there are a lot of applications that came in that I want to be a trust doctor in microbiology, but I'm trained in urology. I'm in urology MS. Would I take them? No. Even if the GMC registration there, I wouldn't take a person who has urology MS applying for microbiology. But if I find somebody who is GMC registered and MD microbiology, then I would shortlist that person. Does it make sense? So it will depend upon the person who is doing shortlisting at that time with your application. So if they find that you are, did you say you have MD microbiology?
Yes, I am MD microbiologist.
MD microbiology. So you can, if you have a GMC registration, you can easily get into a trust doctor.
No, I don't have registration.
Okay. So either you have to get a GMC registration or you have to get the full FRC path and then get GMC registration to get into a doctor job in microbiology.
I don't need to apply for MRCP, so?
No, you don't need to apply for MRCP. So a few months back for CESR, there was a requirement was MRCP. So that was really difficult. Reason being
for consultant maybe.
Sorry?
For being a consultant, I will
for
need
being consultant. Well, let me finish. So for CSR, there was a requirement for you to have MRCP. Because you see, UK doctors, when they're coming through, they have MRCP in there. So they wanted the person who is applying for CSR to also have MRCP. Now, this is very difficult for somebody who has done MD microbiology and hasn't done any medicine for years to get into an MRCP. So we kind of raised a lot of problems and issues with that with GMC and RCPAT. And I heard that requirement has gone now. So those people who are applying for CSR do not need MRCP anymore. So essentially, if you're going through this route, you are most likely do not need any MRCP. But I would suggest anybody who is going for CSR, make sure you confirm it first. Do not go by my word. It's a very new development. I haven't received any document to confirm it that for CSR, you don't need any MRCP. But that's what I heard, which is a very good news.
Okay, thank you very much. And my second question is about the duration of the time between part 1, I mean FRC part 1 and part 2. Can I take these exams 6 months later? I will enter part 1 in spring, and I want to take the others on the September.
I think you can, but I wouldn't recommend it. If you're confident enough, you can go for it, but I wouldn't. I think you can. Nobody has done that in whom I knew that anybody who has done part 1 and part 2 within 6 months. So I do not know from my past experience. I can do it, but it will be a very difficult thing. Even if you can do it, you need to probably ask Royal College, but I think you can do it.
Because I heard something like that in between these 2 exams, you should wait 1 year.
Yeah, that would be my advice. I do not know whether Royal College has, I do not remember whether Royal College has put it in writing that you should be waiting for 1 year, but it might be the case. And if they do it, it will be the right thing to do. I think it is very difficult to take in 6 months. But as I say that I do not want to say something which I'm not sure about. So you probably better look at it. Nobody I know that has done the exam within 6 months.
Okay. Thank you very much.
Okay. Swati?
Good evening, sir. Thank you so much for a wonderful session today. 2 sessions I have attended. And can I know, like, I have 10 years of teaching experience also, apart from being a consultant. So how can we get a job? Like, if I'm interested in teaching for the medical graduates or anything, if I want to get attached to a medical college also. So what is the protocol we have to follow?
This is slightly off the track, and I do not know whether you can just join as a teaching fellow,
Okay.
and how it would work. I have seen teaching fellows in other specialty, but not in microbiology. You probably need to speak to the education department in a deanery. So maybe what you can do is, so there are 2 ways you can do it. One is that you can ask one of the training program directors. So each training program, so UK training program is divided in different region, like Northeast, Northwest, Southeast, like that. So each training program has a training lead called training program director. So I would suggest that you find out who is the training program director of some regions and email them. Ask them whether you can join as a teaching fellow. And other way would be speaking to the education department of a hospital to see whether you can get a teaching fellow job. It is not that common in microbiology teaching fellow.
Because in India, you know that we do multiple jobs. We teach also and we do the lab work also. So like that, I have experience. And now I'm in Saudi Arabia. Here also I'm doing the same thing. Most of the time is dedicated to teaching, but weekly twice I go to the lab also. So if I want to shift to UK, I wanted to know like what is a procedure. That's the thing.
as I say, that it will be something you need to kind of inquire a little bit more.
Okay.
You probably wouldn't get it directly because junior doctor, as a consultant, we kind of get involved in education of junior doctors as like a with universities and things. But as a junior
Yes.
doctor, it will be difficult. But I have seen teaching fellows in medicine or critical care. But I think those people actually found their route by speaking to people. So, or you need to look at the jobs, whether there is any teaching fellow job available, and then also communicate with the education department and see whether anything is available. It will be slightly
Even
difficult.
in some job portals, when we look at the ads, requirement for assistant professor at, take example, Imperial College of London, they call for recruitment of assistant professor in microbiology. They ask for a requirement of FRC path part 2 completion.
Okay, Swati, assistant professor here means absolutely different thing.
Okay.
So compared to India, I know you're from background from India. So assistant professor is very, very different in the meaning is very different in this country. So usually all of us are consultant, and getting into an associate professor, assistant professor, you need to be attached to the university first of all.
Yes.
And
yes.
you need to go through that route. So we do not. I mean, I would probably never go into or get into an assistant professor or professor because I'm not that much into research. So I probably wouldn't go into that way. But those are more like associated with the university.
Okay, sir. Okay, right. Thank you so much, sir. Thank you.
Okay. Sundas?
Hi, sir. I hope you can hear me.
Mm-hmm.
Thank you so much for your presentation, sir. I just had to ask that if we take the FRC path route to GMC registration and you clear both in a year or so, 6 months and then a year later, can you apply for specialty and specialist doctor jobs then? Or is it only locum consultant?
Okay, so if you go through that route, like full FRC and you get GMC registration, then you probably will be kind of going here in this area. So I think unless there is loads of, like, you get a trust doctor post and there is loads of microbiologists applying and there is nothing, then you have to go for a trust doctor. But that kind of thing will probably put you here, somewhere here. Now, but now this job has a requirement. I think there is a lot of years of experience needed, and trust has to be happy with your competency to give you a specialist doctor, because really it's an high paid job. So trust needs to be happy. Specialty doctor, I think you can get easily. Okay. So as I said, this is 33,000, this is 52, then this is around 90,000. So you can see that
at least aiming for 52 first and then later for 90 plus.
Yeah. But you can go to the locum agencies and you can ask, and through them you can get a locum consultant job, and you can get probably some experience and good money as well. So that is another way of doing it.
Thank you so much, sir. Thank you.
Right. Okay, thank you. I think I do not have any more question unless Gulchin has another question.
No, thank you.
No, it's old hand. Okay, right. So thank you very much. Moodle, as I say that it will take few more months, I think, to finish. So bear with me. But there are materials there. So if someone is very keen, they can register. But they will not be getting a complete version yet. Okay. Thank you.